Welcome to the IFRS patient education videos. Today we are going to talk about what is called urethral strictures. Stricture means it's narrowing, and urethra is a tube which takes urine from the bladder and brings it out. What causes these strictures? 40% to almost half of them are caused by what we call idiopathic, which is a fancy name for saying that we don't know what causes it. And 35%, quite a significant portion, is iatrogenic. This has to do with some medical personnel doing a procedure, like passing a catheter or having a look inside. So any procedure, if carried out, can cause a little bit of trauma, which can cause the stricture. And a significant portion could be traumatic. And infection are also known to cause, especially those days when gonorrhea is very common. They will also cause one of the strictures. And how do they present? Most of them are asymptomatic initially because the diameter of the urethra is about 1 centimeter. Till it reaches about 1/3 to 1/4, there are no symptoms. And then you have a poor stream or thinning of the stream. And the interesting thing is that initially, if a patient strains, the stream improves or the force improves. But then later, when it becomes too thin, then there is intermittency because you cannot sustain the force for a long time. And then with infection and back pressure changes, it can cause irritative symptoms. Why do you need to treat it? It's important because more than half of them go into acute retention. In other words, they will not be able to pass urine. And if they don't have the expertise, then we need to put a tube to drain or make them pass urine from the abdomen. And then it can cause infection because there is stasis. It can be infection in the prostate or the testes. And sometimes even back pressure changes can go all the way up to the kidneys. And rarely they can also form stones because of the block. So it's important that it is treated if there is a stricture. And how do they diagnose it? The most common or the best method of diagnosis is to do a urethroscopy, have a look inside directly. See here, this is the full circumference of the urethra, and this is the opening. It becomes very, very narrow by the time patient comes with the symptomatic stricture. Then you can do these special X-rays, which will show the stricture. This is the normal size of the urethra, slightly more because of the block, and this is the narrow strictured area. And if there are facilities for uroflowmetry, it will show an obstructed pattern. How are they treated? The best method of treating is through the endoscopy, like having a look inside directly, as we can see here, and then use pass a guide wire and then cut with what is called a cold knife. Earlier days, just endoscopic treatment will result in recurrence of the stricture, which can be actually worse than the previous stricture. And that is the reason why we started doing what is called self-calibration. Here the patient passes a catheter every day to keep the stricture or the cut area open. This is because any healing process, it becomes the scar tissue becomes much more narrow than what it was previously. So unless we prevent it from happening, it will become stricture. There are other methods like open surgeries where foreskin or mucosa or tissues from the mouth are used for repair, or end-to-end anastomosis or stage repair. But these again are not 100% good or have no recurrence. In fact, even when they do these open surgeries, you'll have to do self-calibration to keep the thing open. Stents have been tried, but again, they are not all that useful. So the important advice is that the patients need to do self-calibration or every day pass a catheter to keep the strictured area open. And ideal time to do is after a bath when you have the privacy, and you need to use a clean, dry catheter and sufficient lubrication. The most important thing is that because you're using just a clean catheter, there are always bacteria which go into the bladder. So you should empty the bladder either with the catheter or pass urine immediately after that to make sure there is no urine or bacteria in the urine which is left behind in the bladder. If this is done, it won't cause any problem. And we generally advise to use a larger catheter which will go comfortably, like a 20 French catheter. And if any time it is not possible to do self-calibration, if it goes with difficulty, then the patient is advised to put in a smaller catheter and then come to the hospital for follow-up with the urologist to cut it and make it bigger, and then start all over the process. When this is done, the recurrence is less than 20% and can be comfortably treated. Thank you.